Very good evening, one and all. So, CCI this time has come forward to discuss yet again one interesting, very novel topic in the field of pulmonary medicine. This is Dr. Vijay Kumar Chennamchetty, today's moderator from Hyderabad, and it gives a very immense pleasure to welcome you one and all, my pulmonary colleagues who genuinely wait for the Thursday evening and to take part in the CCI webinar regularly, relentlessly for the past 6 years. So now the concept today, what we are going to discuss is the treatable traits in interstitial lung disease. So where is this concept we have borrowed from? If you see, we have borrowed from COPD, asthma as well. And then now we are slowly taking this treatable traits, identifying treatable traits in interstitial lung disease as well. And it is working wonders. Example, if you see a interstitial pulmonary fibrosis, IPF patient or hypersensitivity pneumonitis patient or any CTD ILD patient or sarcoidosis, NSIP, whatever it is. So the diagnostic label is very important and essential. It also sometimes informs prognosis, guides treatment, enables the meaningful MDT, but it does not tell the whole story. Even after expert MDT evaluation, only 15% of patients remain, almost 15% of patients remain unclassifiable. More importantly, what we need to understand is two patients of the same age group with the same diagnosis may carry very different outcomes. Why is this happening? This is happening because of various other comorbidities existing in the ILD patients. So the treatable traits approach therefore asks a second equally very important question. Irrespective of the label, what can we identify and meaningfully modify in this particular patient today? So for this, today, the flow will be, I'll be talking on giving a context setting, probably around 15 to 16 minutes talk on this topic. And then to join this wonderful webinar in the panel discussion, we have a star-studded panel across India. Let me welcome Dr. Pratibha Singhal from Mumbai. She's a good friend of mine, and of course, everyone knows across India what Dr. Pratibha Singhal is, and then what she has contributed to the field of both pulmonology and intervention pulmonology. Her clinical work encompasses complex respiratory diseases, bronchoscopy, EBUS, other interventional pulmonology procedures, and respiratory critical care. Her broad experience brings the valuable perspective of looking beyond a radiological label and treating the patient as a wholesome today. Welcome, Dr. Pratibha. Honored to have you in CCI webinar. Next, I would love to welcome Dr. Sanjay Kumar from Patna. Sir is a well-accomplished pulmonologist with extensive experience in respiratory practice, close to around 3 decades. Plus, he brings crucial perspective of managing interstitial lung disease in real-world settings, where resources, follow-up, and access to MDT care may vary considerably. Welcome, Dr. Sanjay.
Thank you.
And it's a sheer pleasure to welcome Dr. Jayaprakash sir, wonderful human being, eminent pulmonologist with rich experience in managing interstitial lung disease. I'm sure today, sir, well, his long clinical journey in respiratory medicine going to enrich our knowledge in this particular subset, that is treatable traits in interstitial lung disease. Welcome, Dr. Jayaprakash sir.
Thank you, sir.
Next, the fourth expert who is joining from Lucknow is Dr. Nandini Dixit. She is academically accomplished pulmonologist representing the next generation of evidence-driven respiratory medicine. Her academic work, research work brings valuable perspective on biomarkers, phenotyping, and evolving precision medicine in respiratory medicine. She represents the bridge between established clinical practice and emerging molecular understanding of interstitial lung disease. A warm welcome to you, Dr. Nandini.
Thank you, sir.
So, without much ado, I would love to go ahead and then present this topic. My dear friends, if you have any doubts regarding the topic, please do write in the chat box so that we will discuss. We have a star-studded panel today. We will ensure that we'll get you the right perspective in this precision medicine of treatable traits in ILD from the panel. And it is very, very important. One, we should not miss the entire forest for the sake of tree. In short, the meaning of this idiom and phrase is nothing but when we reach a tree, okay, we should ensure that it is surrounded by entire forest. That means when we reach a diagnosis of idiopathic pulmonary fibrosis, and then if we don't manage the associated problems like gastroesophageal reflux disease, or is it osteoporosis, or associated pulmonary hypertension, or associated hypoxia, and so on and so forth, it becomes very, very difficult to manage or difficult to take care of the patient holistically. That is the whole idea behind today's discussion of treatable traits in interstitial lung disease. Yeah. So we have discussed, okay, in the context setting itself, I have said very clearly, ILD is not one disease. There's a whole spectrum of 200 plus ILDs exists in clinical practice. They come with a lot of overlapping clinical, radiological, and behavioral features. Unclassifiable ILD is common, and a meaningful minority of cases resist a confident single diagnostic label even after a MDD, even at the expert centers. And coming to behavior varies within the label. Two patients with same diagnosis can follow different trajectories. We discussed this. Comorbidity burden is high. So naturally, when the patients, the ILD, what we are seeing is, it can sometimes in middle age, sometimes in elderly as well. Elderly, as the age increases, the chance of having a comorbidity burden is very high. For example, a idiopathic pulmonary fibrosis at the age of roughly around 60, 65 kind of thing. And if we effectively manage and then control the progression of ILD in these patients with probably, using a good amount of antifibrotic, but if he dies with a cardiovascular accident like MI, then it's a sheer failure in management of patient. So that's why it is very important to identify the associated comorbidity burden like cardiovascular disease, GERD, OSA, sarcopenia, mood disorders, and then give a holistic approach to the patient. Patients want more than a name. So our patient doesn't want a diagnosis whether they want, we are managing it as an IPF, we are managing it as a hypersensitive pneumonitis, or we are managing it as a fibrotic NSIP. It doesn't matter. So what they want is quality of life. Clinically, whether we could stabilize them with their lung function, whether we could address them in overall, maintaining quality of life. That is the most important thing that is there right in front of our hands in the pulmonologists across the subcontinent. I'm sorry. Yeah. So history or the evolution of ILD care, if you say, was clearly in disease labels where single unifying diagnosis drives all management, multiple diagnosis, multidisciplinary diagnosis, where we combine with, clinicians combine with radiological, pathological, and then we come to a consensus about what is the diagnosis that we are handling. Let's look at the behavioral phenotypes. We need to identify the progressive pulmonary phenotype, fibrosing phenotype, because at this point in patients with fibrotic ILD and other than IPF, we need to add appropriate antifibrotic so that, the progression of fall in FVC should be prevented at appropriate time. Endotypes and biomarkers, molecular mechanisms begin to substratify disease. For example, if you see, there is a lot of literature that is going to evolve, or in the pipeline, that identifying sometimes T2 high phenotype also plays a very, very crucial role, and then probably we can manage these patients with biologicals. It's probably, in near future, we may listen that. Treatable traits with patient care, that is, we need to have an actionable patient-specific drivers layered onto diagnosis. So thus, it is very, very important. At the end, we need to ensure we identify the treatable traits. And coming to definition of what is treatable trait. Treatable trait must be clinically relevant, reliably identifiable, and modifiable. So clinically relevant means it should be associated with meaningful symptoms, decline or risk or quality of life. That means it can be cough, it can be FVC, it can be associated osteoporosis or quality of life questionnaire. Coming to reliable identifier, it should be detectable using a validated reproducible clinical or laboratory measure. So we should able to objectively measure how much the patient is doing well after identifying this treatable trait and then managing it with appropriate pathway. So modifiable. And there should be an intervention exist that can plausibly change the trait or its impact. That means once we manage, there should be a measurable outcome. That's what it means. A treatable trait means. A treatable trait must satisfy all these three criteria together, not just one. And phenotype versus endotype versus biomarker versus treatable trait, if you see, phenotype is an observable clinical or morphological pattern, whereas endotype is a distinct underlying molecular or pathobiological mechanism. Biomarker is a measurable indicator used to detect, monitor, or predict disease. That is probably a KL6 level kind of thing. And a treatable trait, an actionable feature meeting all the three criteria above, may draw on any of the three concepts. So diagnosis versus treatable traits, we discuss, we should always ensure that, along with the diagnosis, whether it is IPF or hypersensitive pneumonitis or CTD associated ILD or IPF, whatever it is, along with that, we should identify and label, we should start labeling in the case summary or OPD sheets or IP sheets, that these are the treatable traits that have been identified in this patient, and then we are trying to manage the treatable traits as well. And one of the published data which clearly mentioned that the treatable traits can be from the 4-domain network. It can be etiological, that means drivers of the disease like exposure to the pigeons or some other things, or exposure to immunological issues, that is autoimmunity. Coming to pulmonary domain, lung-specific manifestations, behavioral or lifestyle modifications, extrapulmonary or associated comorbidities. These are the things we'll discuss in detail soon. Coming to etiological traits, as discussed, autoimmunity, and then once we identified either in terms of serology, then we should take appropriate rheumatological referral and then ensure the good dose of immunomodulation is there in this patient. For example, I reiterate, many times in many conferences as well, we pulmonologists hesitate to give full dose of immunomodulation. But when we work in collaboration with rheumatology, it makes our job and patient life very easy by giving appropriate immunomodulation. For example, if you take mycophenolate, majority of times, our pulmonologists stop at 1000 mg, but the maximum permissible dose that we can give is 3000 mg as well. Inflammatory activity, that means clinical radiological activity markers, and then anti-inflammatory therapy should be indicated, and then drug-induced injury, medication reconciliation, temporary link, and then once the drug is identified, then almost more than 200 drugs can cause lung injury and interstitial lung disease. And then example, amiodarone, one of the, or nitrofurantoin, or bleomycin, these kind of things, once it is identified, we should withdraw as early as possible. Antigen exposure, and then we should identify the, with appropriate IG immunoglobulin panel, and then we should try to, avoid, that becomes a very, very key in management of hypersensitivity pneumonitis. Coming to air pollution, there is a lot of evolution of literature regarding air pollution associated and PM 2.5, PM 5.0 particulate material, which can, on chronic exposure, leads to interstitial lung disease. And then we should identify this and also ensure that exposure counseling and then air quality measures should be modified in managing it. Another interesting etiological trait is telomeropathy. For example, if after evaluation, if the given patient is having short telomeres, what we can do? My dear friends, please do understand, telomere length, once it is identified as a short, these patients are, very, very, should not be subjected to steroids. If we give more amount of steroids in these patients, then the chance of, progression of interstitial lung disease is very quick, and then these patients die at a rapid pace. Coming to pulmonary traits, Sanjay sir, can you please mute yourself? And coming to pulmonary traits, progressive pulmonary fibrosis, we have discussed. Identifying the acute exacerbation and giving a bundle care is very important. Associated pulmonary hypertension should be evaluated with a right heart catheterization, and then OSA should be identified with a proper sleep study, and then we should give a CPAP or BiPAP as per the evaluation. Exercise limitation, and then these patients should be evaluated, and then pulmonary rehabilitation should be initiated. Infections should be identified. Now the season of influenza is going, a lot of viral infections are there in the community, and then very likely we should ensure that at the earliest we should identify and treat these infections, particularly probably using the molecular assays like BioFire. Hypoxemia, whether it can be resting, exertional, nocturnal, and then we should supplement oxygen accordingly. Emphysema, CPFV, appropriate bronchodilator therapy, triple therapy when it is needed should be given when the eosinophil count is less than, or T2 less than 150, or if the patient is a candidate of T2 low, then they would be benefited with LABA plus LAMA therapy. Cough, lung cancer also should be identified and treated accordingly. Coming to extrapulmonary traits, cardiovascular disease, frailty, anxiety, GRD, osteoporosis, depression, sarcopenia, malnutrition, fatigue, all these things have to be identified and then managed according to care pathways. Of course, we'll discuss a lot in the panel discussion. Behavioral and lifestyle traits, smoking should be ensured, and then we should motivate the patient to stop smoking. That becomes a very, very important task. Coming to polypharmacy, so as per WHO definition, any patient who is taking more than 5 pills should be considered as receiving polypharmacy. And then ILD patients with all these comorbidities, there's a chance that they are getting apart from antifibrotics and immunomodulation, they are getting other medications as well. So we should ensure that drug-drug interactions are not there, and then manage accordingly. Nutrition is most neglected thing, and then we should ensure the nutrition is built up in the given patient. Environmental exposure, and then should be identified and reduced. Adherence, that becomes a very, very complex issue, particularly in Indian scenario. So we should ensure the compliance to the given therapy. The whole prescription should be monitored, and then physical inactivity should be ensure that we take these patients into rehab programs. Vaccination, a minimum of influenza pneumococcal is mandatory. Of course, we getting the data from the COPD patients, probably we should ensure our patients also receive diphtheria, tetanus, and pertussis. And RSV, of course, it is not available yet, and shingles vaccine should be given. Self-management and health literacy, symptom tracking, and we should educate about their disease and comorbidities so that our patients will receive very good comprehensive care. Let's take an example. Look at this fibrotic hypersensitive pneumonitis patient, 58-year-old, fibrotic HP, ongoing bird exposure at home, declining FVC on serial testing, exertional desaturation, persistent cough, obesity, and obstructive sleep apnea. If you see, this patient has got a lot of traits. Etiological trait like ongoing bird exposure is there, and then pulmonology trait like he is also having declining FVC. That means patient is now belongs to progressive pulmonary phenotype, and there is exertional desaturation, cough as an associated symptom, and associated comorbidities like obstructive sleep apnea should be identified and then treated accordingly. And then in this patient, so at least 2 of the 3 domains above, that is worsening respiratory symptoms or physiological progression or radiological progression, should be identified and managed so that the ILD is managed as per PPF phenotype. Inflammation versus fibrosis. Not all GGOs which is seen in the radiology is a cellular pattern. It can be hidden fibrosis as well. So appropriate immunomodulation is very, very important. And then identify the reticulation, honeycombing, and then if it is upfront, it is present, probably we may need to start this patient on a balance of immunomodulation plus antifibrotic drugs as well. PH-ILD, hypoxemia, and OSA. So these patients classically, will have disproportionate breathlessness, particularly exertional breathlessness, and non-invasive risk stratification using echocardiography, BNP, functional assessment should be done. In the particularly PH patients, they will be benefited with right heart catheterization. I'm sure across India, there are only few centers which are doing this therapy, but we should do this right heart catheterization and confirm the diagnosis, because on confirmation only we can start appropriate therapy, because vasodilator therapy is not approved across the spectrum of interstitial lung disease. And symptoms as a treatable traits like cough, dyspnea, fatigue should be identified. Both pharmacological and non-pharmacological measures should be given to make symptomatically better these patients. And when we look at the acute exacerbation, majority of times, even the literature did miss about acute exacerbation being stated as a one different trait. We should identify these traits because acute exacerbation causes a lot of mortality and morbidity, and particularly when they get intubated, it is very, very close to impossible. We have to shift the patient for transplant by using ECMO only. Otherwise, these patients lose life. In such a scenario, we should identify the possible triggers like respiratory infection, aspirations, air pollution, and then peri-procedural things like surgery or bronchoscopy, and then treat very, very aggressively these exacerbations in this set of patients. Coming to biomarkers and next frontier, KL6. I'm sure many of the pulmonologists across India are using KL6 left, right, and center, but there is enough lack of good guidelines to say what is the prognostic value. So we will discuss in the panel discussion. How to prioritize multiple traits? When multiple traits are identified, it is very, very important. If you look at this chart, okay, those patients who are like high impact and low modifiability, and then high impact and high modifiability, these patients should be prioritized first, and then should try to treat these traits at the earliest. Those patients, those traits which carry low impact and low modifiability, we can deprioritize. Those traits which carry low impact but high modifiability, they can also address with somewhat less priority. And a pragmatic Indian clinic model, if you see, those patients who come to us with interstitial lung disease, essentially they should be screened with a thorough history, thorough examination, saturation levels, spirometry, and basic comorbidity screen should be done. At level 2, focus testing and referral, that is echocardiography, extended PFTs, sleep study, targeted serology, and dietitian and psychology referral should be given. And level 3, so genetics, advanced biomarkers, right heart catheterization, pulmonary hypertension service, and transplant assessment should be done. And then this should be implemented in all our patients. So to summarize, it is very, very important to identify the treatable traits. So remember, so traits means T, transcend the diagnostic label. So we should not get attached with the diagnostic label. We should start treating the treatable traits. Recognize modifiable disease drivers, act on high impact traits fastly, individualize the priorities, treat through a multidisciplinary team, and then share these decisions and reassess. So with this, I would love to close my slides, and then let me start the panel discussion. Jayaprakash sir, any quick comments before I pull on my...
No, sir, I think you summarize most of the important aspects of now treatable traits and ILD. And there, yeah, I think we will go to the panel discussion. Then we will.
Yes, sir. So, Dr. Pratibha.
Yes.
Very good evening. Right.
Vijay.
So let me begin with the very fundamental question. What makes a treatable traits approach genuinely different from simply providing good comprehensive care? Could you illustrate the difference using one patient from your practice?
Yeah. So I think, first of all, you very nicely elucidated that interstitial lung disease is a diverse group of lung disorders, which includes inflammation and fibrosis.
Yes.
It's sometimes one patient has either or happening, or one predominant over the other. And what we are currently practicing when we look at comprehensive ILD care and our multidisciplinary approach is predominantly focusing one on diagnosis, because I think in India, we are still sometimes struggling with diagnosis, before we are moving on to treatment.
Yeah.
And when we are talking about treatable traits, I think we are looking at precision individualized treatment, which could be different from standard guideline therapy. Like guidelines are giving us, okay, fine, if it is fibrotic HP, this is what you should do to your patient. If it is a CTD, ILD, if it is PPF, this is what you will do with your patient. But beyond that, there is so much happening in each individual patient. And you already said so, that we are basically looking at ILD and modifiable traits from our experience with airway disease, both asthma and COPD, and how beyond guidelines, when we look at specific things, we are able to treat our patients better.
Yes.
We even started talking about remission in asthma, which was an unheard, unthinkable thought process some 10 years ago. So in ILD, we are looking at things which are specific to your patient, like labeling. For example, I have a patient with fibrotic HP, two patients of fibrotic HP. One could have inflammatory fibrotic phenotype. The other one could have a predominant fibrotic phenotype with some changes of inflammation on treatment, right? Both patients are going to behave differently. I will need to treat the inflammatory fibrotic phenotype with probably higher immunosuppression versus the fibrotic predominant phenotype of HP. So I think that's where we need to look at our, look at our treatment protocols. You could have patients, this is where sometimes where you have a patient of HP who's in the standard care and not doing well. You would think out of the box and say, let me do maybe a BAL and see there is still lymphocytes despite immunosuppressive therapy, whether there is inflammation ongoing, which is not being treated with my doses of.
So to summarize, it is very, very important to identify all the treatable traits and then start. It's like permutations and combinations.
Yes.
Okay, match what are all treatable traits is there and then identify them and then start treating them, right?
Yeah.
So,
say, for example, the same patient, it could not be, it may not be just the HP, it could be an untreated OSA, which is contributing to the breathlessness or hypoxia or development of pulmonary hypertension. So I think every factor is important. And when we get an ILD patient, we are so caught up with the ILD, we forget to look at other things.
Right. So Sanjay sir, well said, Pratibha. So Sanjay sir, okay. Can I ask you
Just
about imagine a 60-year-old patient labeled as a fibrotic HP who also has a progressive fibrosis, exertional desaturation, pulmonary hypertension, obesity, OSA, cough, anxiety, and an ongoing antigen exposure. Should all these traits should be called as a treatable traits, or do we need to have a stricter criteria to prevent the concept from becoming an endless list of abnormalities? What is your take?
Just you have explained about the treatable traits having the three characteristics. That is, it must be associated with meaningful patient outcome. It must be identifiable with a valid marker or assessment, and it must be treatable. Beside this, we have the terms like comorbidity, complication, and marker of severity. So a comorbidity is simply a coexisting condition. It may become a treatable trait if we can detect it reliably and treat it in a way that improve outcome. While complication may be a consequence of ILD or its treatment, such as pulmonary hypertension or infection, it may still be a trait if it is independently targetable.
Right.
But not every complication is framed in that way.
Right.
While marker of severity may be a sign that disease is getting worse, such as greater symptoms burden or more extensive fibrosis. But if it is mainly prognostic and not directly modifiable, it is a severity marker rather than a treatable traits. So as a practical rule, when we notice any feature, we must ask the three questions to ourselves. Can I measure it? Can I change it? Or will changing improve patient-centric outcome? If the answer is yes to all the three, it is a treatable trait. If not, it is a more likely a comorbidity, complication, or severity marker. So far,
That's fantastic.
So far, so this is concerned, we will have to think accordingly, and they may be taken as a treatable traits, but not always.
Yeah, well said, Sanjay sir. But let me give an example for the delegates. Example, you identify a patient who has got a pulmonary hypertension in a idiopathic pulmonary fibrosis. So yes, we can identify it. We can, it is clinically relevant, but in IPF, pH, can it become a potentially modifiable? Can we use some anti-pH medications, pulmonary vasodilators? Because that will be more counterproductive. So then in this given patient, in this IPF, the pH cannot be a treatable trait.
Yes.
So that's what you need to understand. Simultaneously, if the same patient has got osteoporosis, you have given bisphosphonate and make this patient a strong bones, then it becomes a treatable trait. That's what. And thank you, Sanjay sir. JP sir.
Yes.
Should the treatable traits model be applied only after a confident ILD diagnosis and multidisciplinary discussion? Or can it be especially valuable in unclassifiable ILD as well, where the diagnostic dilemma label remains uncertain? What is your take?
So before answering, at the outset, I thank the Chess Council of India for giving me this opportunity, and especially Vijay for moderating this excellent session. So the question is actually one of the very important questions which we need to understand when we talk about the treatable traits in ILD. Now, as you rightly said, when there is a clinically relevant, reliable and modifiable factor which you think is relevant for the disease process. For example, when there is a patient who is coming is on an chemotherapy treatment, cancer treatment, coming with dry cough and breathlessness. If you think that the culprit drug, for example, bleomycin, is the reason for that, and before you starting investigating the patient in detail with HRCT or other factors, why don't you stop that drug and investigate, which will going to progress the disease? So there itself, that what I am trying to say is the treatable trait model and should not be delayed, or the addressing the treatable trait factor should not be delayed until you get a confident diagnosis. And it should be used alongside with your diagnostic process. And as you said, 50 to 25% of the patients, even after a good MDD, which is I think the gold standard for diagnosis of ILD in most of the cases, still 50 to 25% of the patients, you may not get a diagnosis. And don't wait till you get the final diagnosis. You can address the treatable trait if you think that factor is relevant. So it should go along with your diagnostic process, and treatable trait actually is an independent factor of ILD diagnosis, and it should go along with your diagnostic process. So the question in one word I can answer, the treatable trait factor should not be delayed, addressing that factor should not be delayed till you make a confident diagnosis. It should go along with your diagnostic process algorithm.
So that's wonderfully summarized, sir. So I'll take one more step and then would love to add one important point. So there is enough evidence, my dear friends, whoever listening. So what is happening is interstitial lung abnormalities. I'm trying to give an example. So interstitial lung abnormalities, once it is identified in patient's CT, so you are trying to start a drug which is potentially causing interstitial lung disease, like nitrofurantoin or amiodarone or bleomycin, or like some pembrolizumab, the novel anti-chemotherapy agents. All these things, the moment you see interstitial lung abnormality, better to not to give these drugs, because once you give this drug, these are the subset of patients who tend to develop the ILAs into proper interstitial lung disease. So that means what I want to say is you can identify a treatable trait even before the onset of interstitial lung disease, and then ensure you take care of these patients appropriately. And Dr. Nandini,
Yes, sir.
Yeah. For you, could you please clarify 4 frequently overlapping terms for our audience? What is I have touched upon in my talk, but in brief, that was very brief. So can you please explain what is phenotype, what is endotype, what is a biomarker, what is a treatable trait?
Thank you, sir, for the question. And describing these 4 terminologies, phenotype, endotype, biomarker, and treatable trait, I would just like to say that these are 4 different levels of describing the same patient, actually. Phenotype is what we observe in a patient. Endotype is what is biologically happening with the patient. Biomarker is what we can actually measure and ascertain. And treatable trait is a clinically relevant characteristic which can be targeted with an intervention. Take example, progressive pulmonary fibrosis phenotype in an ILD patient. So the phenotype of that patient will be worsening symptoms, declining lung functions, progressive decline in DLCO, increasing fibrosis on HRCT. Endotype of that patient will be persistent fibroproliferative pathways like epithelial injury, fibroblast activation, extracellular matrix deposition, or telomere dysfunction. Biomarkers can be blood biomarkers, or they can be anything that can be measured, like physiological biomarkers like a decline in FVC or a decline in DLCO or an HRCT extent of fibrosis which has increased, or they can be serum biomarkers which we are frequently talking about like KL6, surfactant protein D, MMP7, CCL18. And treatable trait is something which we target with an intervention. So, for example, in a progressive fibrotic phenotype, we'll be targeting them with early institution of antifibrotics. So, having said that, a patient may start with a diagnostic label of like fibrotic HP or an RA-ILD or idiopathic NSIP for that matter. Regardless of the diagnosis, the patient can develop a phenotype which is progressive pulmonary fibrosis. So, progressive fibrosis can become an important treatable trait, but it should not be the only one. So a patient with RA-ILD can have ongoing inflammation. A patient with fibrotic HP can have an ongoing antigen exposure. So they should be treated as a whole. So I just mean to say that treatable traits in ILD that concept is to move beyond the diagnostic label, but we should not just forget the diagnosis at all, as a whole. So
Right.
they should work in synergy.
Diagnostic label becomes a starting point, and then treatable traits become our targets and of associated conditions as well. Right. Coming to the second round, I would love to call upon Dr. Sanjay. Sanjay, sir. So let us take a practical Indian scenario. A homemaker with a fibrotic HP, no obvious occupational exposure, and routine history that appears negative. How deeply should we investigate domestic antigens like birds, mold, air coolers, humidifiers, grain, and so on and so forth, biomass, concealed dampness, and what constitutes meaningful antigen avoidance in such a patient? Is removal of birds sufficient, or must the entire environment should be remediated?
Well, it's a common condition in our scenario. Of course, birds are important source of antigen exposure, but other sources are also there which may not be identifiable easily. So both domestic and environmental antigen exposure is also very important. And these antigens may worsen the patient condition. So we will have to search for the other antigenic exposures also. And meaningful allergen avoidance is not just one isolated step. It is sustained, multi-major reduction of exposure to allergen with enough intensity to plausibly change symptoms or patient outcomes. So meaningful allergen avoidance is basically targeted to a proven sensitization, implemented consistently, comprehensive enough to reduce exposure substantially, and it must be associated with symptom improvement, reduced medication need, or fewer exacerbation. So multi-major strategy is needed to keep entire environment healthy, rather than just looking for one allergen. Allergens which the patient may not notice, but the patient may expect.
Yeah, to probably, to sum up in a single line, we should have our antennas open for broad things, not for only one focused thing. So be cautious, try to get the very good history and ensure the avoidance of antigens should be a multifold, not a single, which appears visible, may not be the culprit. There may be a hidden thing as well. Thank you, Sanjay sir. JP sir, so generally when we look at the CTs of the patient, the ground glass opacity is frequently interpreted as a cellular active inflammation, and then we pump up steroids. But the ground glass may represent inflammation, fine fibrosis, sometimes infection, sometimes edema, sometimes it can be even an acute exacerbation. How do you decide the inflammation is truly an actionable trait? And as an expert, how do you take it forward?
Okay, again, an important question. So basically, in the clinical perspective, when you get an HRCT, there are two patterns. Now, either it's a cellular or a fibrotic. It matters in terms of treatment. So we need to understand what is an ground glass area. Ground glass area in HRCT means a high attenuation lesion or opacity through which you see the blood vessels. No, it doesn't mean that there is an active inflammation alone. Other conditions like infection, fluid overload, etc. can also produce ground glassing. So you have to go along with other factors like the bowel cellularity, maybe the histopathological examination findings, all has to be correlated before jumping into the decision of starting steroids, corticosteroid. So again highlighting that cellularity, a ground glassing may indicate an active inflammation or an infection, and seeing the ground glassing alone, you cannot jump on starting the corticosteroid. Unfortunately, we don't have any biomarker in which you can do and you can document that it is because of an inflammation, not an infection. So when you rule out infection and other causes of ground glassing, which can come in patients with ILD, then you can confidently say that the ground glassing which is appearing in the HRC is due to inflammation, and probably you can start on steroids. And before giving steroid, you should realize or think that if I give steroids or an immunosuppression, what benefit or really the patient is going to benefit? If your answer is yes, then you can definitely start the patient on a steroids because of the background of ground glassing. That's what I want to conclude.
No, I 100% agree with you, sir. I would love to add one more point here. Yes. Sometimes what will happen is when you look at GGO, and you have to match with history whether the patient is also having fever. The febrileness can also because of infection, or sometimes it can be because of active interstitial lung disease as well. So sometimes maybe sending a Procal, maybe sending a Biofire, maybe sending a NT-proBNP to rule out LV dysfunction and pulmonary edema, or sending a KL6 level to measure the fibrosis index, and then probably there is no role that KL6 will add a great as a determinant to say that the amount of fibrosis. But again, this can be if Procal negative, NT-proBNP negative, and there is no active infection going on, then KL6 turns high, then even GGO may predict the underlying fibrosis.
This is especially important when an ILD patient coming with acute exacerbation.
Acute exacerbation.
Yeah, so
agree with you, sir, 100%. And Dr. Nandini, so
yes,
in a patient with NSIP pattern, positive autoantibodies and subtle systemic features, but no classifiable connective tissue disease, how do you approach this autoimmune trait? Should an antibody such as anti-synthetase syndrome influence treatment even if the formal CTD criteria are not met? Where does IPAF help, and where can it potentially mislead us?
So, classification criteria for CTDs given by EULAR were primarily designed to create a homogeneous cohort of patients, and failure to fulfill them doesn't necessarily mean that there is complete absence of biologically meaningful autoimmune disease. So I would say, like, if a patient with an ILD pattern of NSIP-OP with an anti-synthetase antibody which is positive, we should still consider, and a subtle CTD abnormality like just a Raynaud's phenomena or just a mechanical hand, we should still consider them to be an inflammatory phenotype, because per se anti-synthetase ILD are a triad of muscle inflammation, arthritis, ILD, but they necessarily do not coexist at presentation. And specifically, patients with anti-PL7 positivity, PL12 antibody, EJ positivity primarily present with ILD per se. So just treating them as a fibrotic phenotype would be giving them less treatment. And talking about IPAF was also a research classification. It was not a treatment algorithm. So there can be two sets of patients. A young patient with an NSIP or OP pattern and an anti-synthetase antibody with a subtle history of Raynaud's phenomena. In that patient, we could consider inflammatory phenotype. But another patient who is sick, old, or is having a frank UIP pattern on CT with just an ANA positivity and an inflammatory arthritis, in those patients, I would think that consider them a fibrotic will be more beneficial for them, and would be the clinician's decision. So labeling them all under the IPAF umbrella would be like giving them false therapeutic equivalence.
Right.
That's all.
So it is very, very important to understand. So IPAF associated features should be taken into the consideration, and then based on the clinical scenario, we have to give the strength to treatment, and it should be individualized. That's what Dr. Nandini mentioned. And
can I add something here, Vijay?
Yeah, please.
Yeah. See, I think CTD ILDs are the ones that are the most difficult sometimes to manage, because here we're talking about where you have an autoantibody positive, but so many times the CT looks like like probably a CTD related ILD, and you don't have any,
ILD. Right.
and you don't have any autoantibody positive with no
Right.
extrapulmonary manifestations, and patient is progressing. I think so. CTD ILD, I think, is something that we unfortunately have not been diagnosing enough. It is probably equally existent as much as HP in our country. It's just that we are missing a lot of CTD ILD. So I think when you get CT features which could probably look like a CTD ILD, and you have some autoantibody positive and it's fitting the clinical spectrum, I would not hesitate in
Giving
continuing some form of immunosuppression, because eventually the driver is inflammation.
No, 200% correct. If you look at the literature, Pratibha,
Yeah.
so what happens is in ANCA-associated vasculitis associated ILD,
Yes.
there are a good number of, sometimes even the published literature says 30 to 50% of times ANCA is negative. But if you see the CTs, it looks like almost burnt out lung.
Yes.
So we should not wait and then watch. You brought in the very, very important point, which will be useful for all of us, particularly those who are now learning the interstitial lung disease management. It is a very, very strong point. Please make a note, and then please consider it as one of the take-home point. And for you, Pratibha, genetics and short telomeres are increasingly discussed as treatable predictive traits. So which red flags should prompt telomere length and genetic evaluation in routine ILD? Particularly in India, what is happening is the genetic evaluation is the most neglected thing in ILD patients.
Yeah. I think familial fibrosis in close family members and relatives, then if the patient themselves presents with a idiopathic like pattern with at a younger age, less than 50 age, or if there is early graying, or if there are other liver abnormalities or bone marrow abnormality presentations, which can all happen with the short telomere syndromes. The problem here is that at this point in time, we don't really have any treatment dedicated to it, right? There is some trial that is going on the efficacy of danazol in patients with fibrosis and short telomere, but there is no standardization or approval yet. So for us, it's more of a prognostic significance risk management and also for family counseling, whether other people in the family also need to undergo this. The only one thing that I can say is that one of the variations of the TOLIP gene has in IPF specifically, there is one trial which shows that probably giving N-acetylcysteine in them is actually beneficial. So, compared to where we know that NAC doesn't work for the other ILD subgroups. And overall, as such, I think if you have a short telomere, irrespective of the diagnosis, patients are prone to progress faster. So I think the only thing where it could have a prognostic significance and impact is maybe you could introduce an antifibrotic earlier, then wait for the full-blown PPF, the guidelines that are given, and also maybe list them for transplant earlier. Maybe now that we have options of transplant in our country, start having the conversation earlier than later.
Right.
Ideally they say that you should start talking about transplant at the second, third visit of diagnosis. But I know realistically in our country it doesn't happen.
Right.
You can't talk to them about such expensive treatments when we're still trying to talk to them about future antifibrotics.
Right. So I 100% agree with you. And I just want to add one more point, whatever Dr. Pratibha says. See, my dear friends, if you identify at a fibrosis at a younger age, like 50 years or something like that, make sure you rule out a short telomere, because short telomere, if it is associated, you should not pump in steroids, which I mentioned in my talk as well. Yeah. Second, NAC may have a role, and then early initiation of antifibrotics before the full-blown development of fibrosis may have an impact clinically, and then make these patients, quality of life, a better one by initiating early antifibrotics.
Yeah, and one thing that you said, Vijay, is very important is that, some patients who standard dose of MMF, say, for example, they get recurrent infections. Yeah. Maybe those you should probably think of doing a genetic testing. Maybe they have a short telomere because those are the ones who don't tolerate immunosuppression very well.
No, not even 0.1% of our patients are getting genetic evaluation, Pratibha. Yeah, totally agree with you. Okay. I think after this webinar, even I am taking, seriously, because I read a lot for this webinar. So I must also, I will ensure that whenever that strong suspicion comes in practice, I ensure I'll send these patients for genetic evaluation. A strong point for all of us to make a note. And JP sir.
Yes.
Now we are going to round 3, where we will be discussing on pulmonary traits, progression, infection, and physiological complexity. So consider a patient with CTD-ILD, sir, receiving appropriate immunosuppression, who develops worsening symptoms, an absolute FVC decline of 7% and radiological progression over 1 year. When should we declare progressive pulmonary fibrosis? Should antifibrotic therapy be added, substituted, or delayed while immunosuppression is optimized? How do you distinguish treatment failure, or the point of where the patient has diverged and then started moving across a progressive pulmonary phenotype? What is your take, sir?
Okay. So the question is, when will you label a CTD patient into progressive pulmonary fibrosis category, PPF category? We have good literature or guidelines, ATS, ERS, giving clear-cut instructions for when to diagnose that. Basically, a patient who is a CTD, you look into 3 factors. Number 1 is the physiological, the physiological, like the symptomatic deterioration. How far the symptoms are deteriorating. Number 2, the functional deterioration indicated by the spirometry, especially the forced vital capacity, which is falling more than 5% for reduction. And you can look into the DLC also, which also more than 10% fall. And there is a radiological deterioration in terms of fibrotic features, meaning to say that there is extensive septal thickening, reticular shadows, traction bronchiectasis or broncholectasis, honeycombing appearance in the new CT, which is done within an year. So look into 3 factors. symptomatic deterioration, function deterioration, and radiological deterioration. If any two of the three are present, and you can suspect or you can label the patient as a progressive pulmonary phenotype, then before jumping into antifibrotic treatment, you have to look into the scenario where the patient is on a optimized immunosuppression treatment. If there is still a hope for giving immunosuppression adequately, you optimize that. And still the fibrosis progressing, you can add an antifibrotic agent. If the immunosuppression is not working well adequately, you can actually replace with antifibrotic agent. So a progression doesn't mean that you stop all medications and give antifibrotic. No. So you have to consider the adequate treatment which the patient, the level of immunosuppression, and decide on starting antifibrotic agents.
So as JP sir rightly mentioned, so it is the balance and close follow-up is very, very important. How much is the immune mediated? How much is the transition to fibrosis? We have to assess by clinical judgment and also objective measures, like as sir rightly mentioned, FVC drop more than 5%, DLCO drop more than 10% in less than 6 months time should be considered aggressively as a progressive fibrosing phenotype. And then apart from if immunosuppression is not managed properly, enhance the immunosuppression. And then if the patient fits into the criteria of PPF, do not hesitate to initiate antifibrotics. And I'm sure in the near future, probably in 3-4 months time, to the basket of what we have, pirfenidone and nintedanib, we're also getting nerandomilast to Indian market as well. So Nandini ji, so PPF is arguably the most successful example of phenotype transcending diagnostic labels. But the current criteria require documented progression. Are we waiting for the patient to lose lung function before acting? Could there be any role of biomarkers or predictive models eventually identify a high-risk PPF signature before irreversible damage occurs in the lungs?
Sir, very rightly said. Actually, the present PPF definition is telling us the patients who have already progressed. They are already demonstrating functional, clinical, or radiological decline. We have no means to detect who are the patients who are at risk of progression. So basically, biomarkers will have a role over there. So we have predictive prognostic biomarkers, but they are of not yet validated. Out of them, only a short telomere length is being used to detect familial ILDs. Other than that, we don't have such markers which are validated. We also have upcoming FAPI PET, which will actually be detecting activated fibroblast in the interstitium, which will give us a clue whether there is active fibrosis ongoing so that we can institute early antifibrotic therapy. But as of now, the PPF definition is is just delineating those patients who have already showing progression. And coming from an Indian background, Indian settings, patients are coming to a tertiary care center when they are symptomatic already for 3 years, 4 years, and they are already coming with grade 3 clubbing, hypoxia at rest, low baseline FVC and DLCO. In such patients, I agree that we should either give them if they have a fibrotic phenotype like a UIP pattern, we should think of starting antifibrotics upfront and simultaneously looking for the actual diagnosis of ILD. Or we should go subject this patient to early functional assessment like at 3 months or 6 months with an HRCT or a PFT to look for progressive decline, and then early institution of antifibrotic therapy, and just do not sit with the definition of PPF to let them progress.
Right. I agree with you completely. Just to add, Dr. Nandini, for your comments, yes, there may be very good role of biomarkers, and then more importantly, what we need to understand is artificial intelligence is coming into the management of interstitial lung disease, for that matter, even respiratory medicine, left, right, and center. And then I'm sure we are not even, few years away. So there will be a lot of guidelines that will be coming using appropriate predictive models, using deep neural networks and all those things. So we are going to have a lot of evidence in probably 2 years, 3 years from now, which will dictate us how to pick that single point where the patient lost the classical path and then started behaving progressive fibrosis phenotype. So this is not far off, and I'm sure our patients are going to get benefited from the AI and then biomarkers in near future. Pratibha,
Yes.
ILD patients receiving immunosuppression commonly develop infections. While infection itself is a mimic progression, pneumonia also we think that it is a progression. But how do you differentiate infection, inflammatory flare, or disease progression, or acute exacerbation?
Yeah, so very good question, and very complex clinical dilemma for most of us who are treating ILD patients. And basically when we look at progression, we are obviously saying that it is something that is not happening in a matter of few days. It is over a few weeks or maybe over a few months as well. So obviously there will be clues to that. Patient will have a gradual progression of the disease. When we talk about acute exacerbation, okay, often it is, at least in our setup, a lot of times I see 50% of the times it's because of infection. Though it becomes difficult to really pinpoint that because a lot of times these patients are already on immunosuppression, so they may not present with fever. They will just come with increased breathlessness, maybe some increase in inflammatory markers, maybe some increase in cough with little sputum production. It may not even be purulent sputum because a lot of times it's even viral infections. I mean, currently we are seeing a lot of viral exacerbations of our ILDs, flu exacerbations of our ILDs. So I think it will have to be, you will obviously do a CT scan in a scenario like this. You will see if you're getting some obvious consolidation. So there it's a no-brainer, okay? With the proper clinical context, you'll say it is infection. If you're getting GGOs, if you're getting some increase in septal thickening, you'll obviously have to rule out other things like maybe there is no cardiac failure that is also concurrently happening in these patients, which could explain these findings. Or if you are talking about a flare, which we are specifically relating to CTD ILD, okay, so that is obviously going to happen in context of a flaring up of the CTD. If you have a patient, like a couple of weeks ago, I had a patient who had increase in her joint pains, which is
Right.
RA-ILD, and then when we did a scan, we found there was a progression. So we're
Right.
obviously looking at that, we realized that our immunosuppression was not adequate and we needed to up the immunosuppression. She'd been stable for a year, but then now she needed increase in immunosuppression. She was already on antifibrotics. So I think it's a very clinical call. Doing a sputum testing, doing PCR-based tests, like what we do, BioFire. I know BioFire has a lot of negative things. Also, they say you're just sending BioFires. It is so expensive. But I think in our ILD patients, it's going to be of extreme importance because you're going to be reluctant to do a BAL in a patient if they're not producing, adequate sputum to actually go in a patient who's on 7-8 liters. You're not even going to get consent from the patient, right?
Majority of time they don't give a consent.
There could be an exacerbation or a worsening of your ILD further. So they're not going to give you consent for doing a bronchoscopy. I mean, however, I really admire the West for being able to do more invasive procedures than we are able to. I don't know how they convince their patients, but I've seen it firsthand that their patients somehow agree to a lot more interventions in more serious situations than we are able to convince.
It's a quite challenging task back in India. In our practice, what happens is, if a patient, anyhow, let's assume a IPF patient having an exacerbation, he is already in intensive care unit, requiring some amount of NIV support. This guy, whatever you do, there is a chance of 30 to 50% we are going to lose this patient.
In ICU, 90% if they go.
NIV, okay, 90% sometimes. So in these patients, if you intervene and then if the patient is lost,
yes,
then there's also a possibility that the family attributes mortality to the procedure.
Yes.
So BAL has a as Dr. Pratibha very clearly mentioned, BAL has a very, very limited role. Unless your selection of the patient, unless it is mandatorily required, do not subject these patients for bronchoscopy or lavage. That is counterproductive.
One additional point. Please take a death on table consent. or
Yes.
a death post, because you'll be surprised that sometimes when you are at a loss,
And
even family may be
more
willing to
importantly, Pratibha, what I would love to ask you is, so do you think a ball will add anything in these scenarios? It is
No.
not going to add. Don't do it.
No.
There's no need to take any high risk consent on it. Don't do it. Okay. Another single point I want to add, whatever Dr. Pratibha said, is sometimes what we may miss is a pulmonary embolism or a pneumothorax also can be seen in these patients. Please be cautious, identify, and then treat accordingly. And then to summarize, progression, it takes its own course, very slow, as Dr. Pratibha mentioned. But acute deterioration, you can think of any pneumonia or viral infection or an exacerbation, in short, and bronchoscopy, a definite no in acute scenarios. Sanjay sir, how should we monitor progression in CPFE, where emphysema may preserve FEC while DLCO is disproportionately reduced? Which combination of symptoms, imaging, exercise testing, physiology gives you the most reliable longitudinal picture?
In this type of scenario, no single test is good enough for longitudinal monitoring. So we will have to take a multi-domain attitude for a reliable picture. And combining symptom burden, physiology of the lung, exercise metrics, and imaging or functional testing, all are important to combine. So we will have to track the symptoms, physiology, like serial spirometry, DLCO, resting oxygen saturation, exercise desaturation, and if possible, CPET. Exercise performance again can be helped, like 6-minute walk test. And lastly, the imaging, HRCT. It is important to see the structural progression, but less suitable than the physiology. So symptoms plus spirometry, DLCO, 6-minute walk test, all is usually the most practical and reproducible set of for these patients. Sometime 1 minute sit and to a stand test may also be done as complementary to other tests. Only PVC alone is an inadequate anchor. It can miss air trapping, effort variability, and gas exchange worsening. So we will have to combine symptom, physiology, exercise performance, and imaging all together.
Thank you, sir. Thank you so much. But again, these are the patients where, before jumping into next round, these are the patients who are high likely threshold of sitting and landing into a pulmonary kind of scenario. Pulmonary hypertension should also be. Echo is very difficult to do in these patients because of suboptimal window. And then it requires a lot of expertise to calculate RVSP and then TR jet velocity and then TAPC values in these patients. But it can be done. It should be done to ensure, even if it is pH is worsening in these scenarios, which has to be evaluated appropriately. Thank you, Sanjay sir. Coming to the next round, the overlooked burdens. Whatever we see, we are now enter into a phase where the least bothered things are pulmonary hypertension, sleep issues, symptom management, rehabilitation. These are all the things we generally stick to, more rigid, and then stick to the prescription, medication kind of thing, and then we'll stick to the core disease label. But these missed entities will be discussed in this round next 10 to 15 minutes. I request Dr. Nandini to comment on pulmonary hypertension prevalence in interstitial lung disease, which clinical, physiological, radiological, or echocardiograph signals should trigger the recommendation for right heart catheterization in our ILD patients.
Thank you, sir. Sir, in patients with lung disease, as per the current ERS guidelines, severe pH is defined as an MPAP of more than 35 or an MPAP of more than 25 with a low cardiac index. So there are a huge subset of patients who have pulmonary hypertension associated with ILD, but only less than 10% of patients with advanced ILD will have a severe PH. So only patients with severe PH who have a relatively preserved lung function like an FVC of more than 70% and a rapidly declining DLCO with clinical features of out of proportion dyspnea and CT features of an enlarged pulmonary artery and RV enlargement, septal flattening and cardiac biomarkers like an elevated BNP level and echo findings of which are difficult to ascertain however, but echo findings of a dilated RARV or a tricuspid regurgitant jet of more than 2.8 meter per second. Only those subset of patients I would consider them for subjecting them to a RHC, because RHC should only be done and reserved for those patients in which it is going to alter our treatment. So only to exclude those patients of primary PH. So if it is a group 3 PH, there is no major role of, we don't have interventions to offer to the patient. So I would not subject those patients to an RHC upfront.
So now the most important associated question I'll ask. How many of patients are really getting RHC?
No one.
Zero. You agree? Zero, right? Right. So yes, we at Apollo probably 3%, 4% of patients are willing to get, and then probably we will suspect and then we'll refer. And thanks to Professor B.K. Shastri sir, who hails from Hyderabad, who practice in Hyderabad, his availability and his expertise will take in terms of requirement RHC is required. Otherwise, if any cardiologist is listening, please, enough of concentrating on left heart. Please come and focus on right heart. There is a lot of scope of building not only practice, your familiarity, and then a unmet need, severe unmet need can be addressed if you develop the skill of doing a very good right heart catheterization. Thank you, Dr. Nandini. Coming to Dr. Pratibha, inhaled treprostinil has changed the conversation around PH-ILD, whereas several earlier pulmonary vasodilators were neutral or harmful. While PH-ILD patients should be referred for disease-specific therapy, and why should clinicians resist empiric sildenafil, a general PH-style treatment?
Yeah. So I think
Most
Nandini
important question
already
of the day.
Nandini has already set the stage. So I think the guidelines very clearly mention that for group 3 pulmonary hypertension, especially in ILD, there is very limited data. Whatever older studies we had, which was the Artemis trial with ambicentran and IPF, or the RISE trial with riociguat, have both shown a deterioration in the disease with the addition of these drugs. Firstly, as you said, hardly any patients are undergoing a right heart cath. We are not even certain whether they really have PH or not. So I think starting therapy cannot happen without first confirming there is pulmonary hypertension without, with a right heart cath. And secondly, so the other issue that happens with vasodilator therapies, like sildenafil and all, is that may increase the VQ mismatch. So I think what currently the guidelines are saying in mild ILD, okay, is that with group 3 PH, is that very individual case to case based, you could consider sildenafil, but that should not be by us. It has to be by a pulmonary hypertension specialist after having done a right heart cath.
Yes.
So at this point in time, probably if your patients are not undergoing a right heart cath, they don't deserve to be started on treatment. Okay. And it should not be just by ourselves. It has to be a multidisciplinary approach involving a pulmonary hypertension specialist. And as you said, there are few and far in between.
Pratibha madam
selectively did not commented on inhaled treprostinil.
No, I did. So that trial has shown to have benefit. So that is the only trial that has.
But it is not available.
It is not available.
It's not available. That's a major constraint.
Yeah, in
Yeah.
fact, interestingly, that
Yeah,
trial not only
I
had
would love to
benefit,
listen this comment. Right, please go ahead.
not only had benefit in the pH, but also there was an improvement in FEC in these patients.
Yeah.
So it was a very secondary outcome, unexpected outcome. So we are very looking forward.
That's how the Teton 1 and Teton 2
Yes.
has come.
Yes.
And then the inhaled treprostinil has become a wonderful antifibrotic as well,
Yes.
apart from pulmonary vasodilator.
Yes.
Right.
So you were going to say something, Dr. Balakrishnan. I think he was going to say something.
No, I just want to clarify. It's a wonderful point you brought out. Suppose there is a patient with disproportionate pulmonary hypertension where RC is not possible. Are you justified in starting and that's what perspective I'm asking.
I think if there is a CTD ILD where you are probably thinking that there could be a component of the pulmonary vasculature involvement because of the CTD itself, then you could, as I said, have a multidisciplinary meeting and take a decision with the cardiologist, rheumatologist, and then take a with
Otherwise, the
consent.
biggest challenge is it is going to worsen the VQ mismatch, and then it can compromise. But again, in the ERS guidelines, European Society of Cardiology guidelines, it says if the pulmonary hypertension reach to such a level, very high, severe pulmonary hypertension, it is worth trying at that point with pulmonary vasodilators like sildenafil, otherwise not. JP sir, over to you. Any quick comments you want to add there, sir?
No, that's what I want to clarify. Same thing.
Yeah.
I think we are waiting for the new drug. I think it will make a wonderful change.
Yeah. So coming to JP sir, OSA and nocturnal hypoxemia are remarkably common in ILD patients, but frequently missed. Whom should we screen with overnight oximetry? Who needs a formal polysomnography? And would you, how do you treat with them CPAP, BiPAP, APAP? What do you do?
As you rightly point out now, hypoxia, especially nocturnal hypoxia, is very common to the tune of 35 to 45% in patients with ILD. And we must understand that nocturnal hypoxia and OSA are two separate entities. And probably both are potentially treatable traits also. There's nocturnal hypoxia and OSA. But I would suggest to do a overnight nocturnal testing, hypoxia testing, if the patient has a nocturnal hypoxia, excessive breathlessness, a daytime headache, or excessive fatigue. You must understand that daytime normal saturation will not rule out a nocturnal desaturation. So when there are situations where the patient has a morning headache, there is a hypoxia or a excessive fatigue, you should do a nocturnal and overnight hypoxia testing.
Oximetry.
Oximetry. And I would prefer to do a obstructive sleep apnea or a polysomnography study when I suspect a patient with symptoms of a daytime sleepiness, snoring, the usual symptoms of an obstructive sleep apnea. And along with a disproportionate pulmonary hypertension also, I would suggest to do a polysomnography, which otherwise you will going to miss. And in one point, I can say in our even ICS and CCP also recommend to do a polysomnography in ILD patients with a high BMI or a symptom which give a score for suspecting obstructive sleep apnea. In that group of patients, you can do a full polysomnography for ruling out associated obstructive sleep apnea.
JP sir is saying very clearly, those patients who are otherwise fitting into through when we screen through stop band, Epworth sleepiness scale. Yeah. So if they are getting higher points, these are the patients, they would be benefited with polysomnography. Otherwise, those are the patients with an unexplained headache and then fatigue. These kind of patients, probably you can get away with overnight oximetry and then manage accordingly. Yes. Thank you, sir. And then quickly, I also request you to know whether you want to add just oxygen alone or CPAP or BiPAP, AVAPs. What is your choice in these patients, sir?
No, when there is a hypoxia alone, probably oxygen will suffice, it will help. But when there is a documented obstructive sleep apnea, I know the CPAP will address only the upper airway obstruction. But when there is an overlap syndrome, like patients with along with other respiratories like COPD or an ILD, probably a BiPAP will be better tool for addressing the coexistent OSA along with the chronic respiratory lung disease.
My dear friends who are listening, for which JP sir has brought in very wonderful concept of overlap or obesity hypoventilation. So these are the patients where you check a ABG level. If the bicarb is more than 27, that itself is a very good indicator that this patient is retaining carbon dioxide, chronic retainer. And these are the patients you should try to avoid using autopap, and then you should try to start using BiPAP with ST mode as a preferred choice, or AVAP or IVAPs kind of thing, as per different companies which algorithms that are available in the market. Thank you, sir. That's a wonderful way of summarizing for that question. And Sanjay sir, can you please throw some light on how do you systematically phenotype and manage the symptoms like cough, dyspnea, fatigue, without attributing everything to fibrosis?
The best approach would be to phenotype the patient by dominant mechanism of symptoms, not by FVC alone. Because cough, dyspnea, and fatigue may often reflect a mix of fibrosis, airway disease, hypoxemia, sometimes pulmonary vascular disease, cardiac disease, anemia, hypothyroid, and etc. A lot of things. So start by separating the patient into the one or more symptom dominant phenotype, like cough dominant, dyspnea dominant, or fatigue dominant. So systemic workup of ILD assessment to do by proper history taking, proper physical examination, good lung physiological study, HRCT review, and sometimes non-pulmonary screening like CBC to look for the anemia, ECG, ECO, etc. And we should target the management in parallel rather than sequentially, because it is better. So we will have to look for the fibrosis progression, which will have to look for the cough, dyspnea, and fatigue. And it would be better we make a practical rule for to just look for the three questions that a patient come, that what symptom is most burdensome, what objective abnormality best explains that, and what else could be contributing beside fibrosis. So multidisciplinary care pathway is better, and this approach is just better than just treating the declining FVC. So we will have to take care of all these things.
Right. So very well said, Sanjay sir. I would love to add a couple of points here, my dear friends. So if you see in all the ILD patients, almost all these patients, GERD plays a very, very crucial role. So once we manage GERD, the cough will be maximum, we can control it. And then those patients, despite optimizing GERD control, then if the patient does have a cough, then probably you should use some neuromodulators like gabapentin, pregabalin, and then gefapixant. So many new promising drugs are on its way. And then sometimes we may need to use codeine, morphine, or morphine analogs like tapentadol can be used in management of thing. And simple strategies like handheld fans can abate the dyspnea in these patients. So such a kind of things should also be recommended, prescribed to the patients, discussed with the patients so that they feel symptomatically better. Now we'll move on to, I can see in the group there is a mentioning by Dr. N.H. Krishna Anna, our founder, chairman, trustee. Okay, there are 2000 plus 2101 logins so far for this webinar. And thank you, Krishnana, and then thank you, Lupin, for that wonderful circulation of a very important webinar. And then without your active marketing, this amount of logins is close to impossible. And coming to next round, acute exacerbation as a preventable trait. Let's discuss. Dr. Pratibha, okay. So can you please tell, do you agree, even though an acute exacerbation is an event rather than a persistent phenotype or an endotype?
Yeah, so I think even though the initial articles did not include exacerbations as part of the treatable trait, the subsequent articles have included exacerbations as part of a treatable trait. I think what they're basically trying to tell us is more about patients who are susceptible to exacerbations, because we still don't have really recommendations for acute exacerbations. Steroids are given, but of limited significance, controversial. We treat patients with based on whether they have infection or not. So I think what they're basically saying is that we recognize patients who are at risk for exacerbations, like patients who have advanced disease, patients who have environmental exposures, pollution, winter season. Some patients have, prone to developing exacerbations in winters, especially when they are living in close quarters, especially in our country, some lower socioeconomic. They very often come in exacerbations when there is overcrowding or when they have not been vaccinated. So I think that is what basically they are trying to say, is that we address this rather than, and that's what, rather than saying that exacerbations are a treatable trait, because treating exacerbations, we don't really have guidelines, right? There is no real treatment for treating exacerbations other than giving antibiotics. Though there is some data that says that a chronic bacterial load and neutrophilic inflammation could cause progression of the fibrosis. So I think that is what we are wanting to target, is prevent a chronic bacterial colonization, prevent recurrent infections, because that is going to cause progression of the fibrosis.
Right. I think, Pratibha, ILD vertical is trying to get a lot of inputs from how we manage COPD.
Yeah.
So COPD, one moderate exacerbation or two moderate exacerbation, and then one severe exacerbation, you change into triple therapy, or you add biologicals in management, like that. I think slowly we are moving there. And then it is very, very important, because exacerbations lead to higher mortality.
Yes.
So we need to cut down, identify this as a preventable trait, and catch hold of it at a bud level and should nip it off. Sanjay sir, in a patient with previous interstitial lung disease or interstitial ILD exacerbation, what would your practical prevention bundle when after an exacerbation he visits you at your office for a follow-up? How do you like to see him as a bundle, and then what you would do differently?
So far, so the exacerbation is concerned, we should. It is always better to prevent it rather than to have a first look treatment. And of course, as Pratibha Madam was telling, that a lot of factors may lead to the exacerbations. And of course, vaccination is one such point that can prevent the infection and exacerbation. And of course, because every attack of infection can lead to higher mortality, higher hospitalization, and healthcare cost also increases. So we will have to have the vaccination, and again we should look for the other factors like aspiration risk reduction, potentially actionable trait like anti-GRD measures, anti-reflux surgery in some cases, pollution avoidance is also very important. So we will have to look for all these things, and of course, antifibrotics. It should be given in the patients who have the fibrosis or the progressive fibrosis. So all of these to be taken care of.
Thank you, Sanjay sir. So as we will be closing in next 10-15 minutes, so I'm not giving any additional comment. Now I call upon to Dr. JP sir. So absence of evidence is not equal to evidence of absence. Hope many of Indian pulmonologists who are academicians and sought after pulmonologists also will agree this statement. Sir, before the procedures and surgery, there may be no chance that our ILD patient may be asked to for a pre-op evaluation for lap cholecystectomy or hysterectomy, or for that matter, sometimes bronchoscopy also can lead to some amount of exacerbation. Sometimes a thoracic surgery like wedge resection, or there may be identified cancer at stage 1, and then this patient can benefited with potentially, if you subject him to surgery, there is a potential curative chance of 85%, 90%. How do you handle such situations in day-to-day life, sir?
Okay. You said actually the situation that the surgery is beneficial. If not, I will discuss the surgery. Can you avoid the surgery? If they say that it is beneficial and we have to proceed, then I will think of a few points. Number one, how the patient clinical examination, the status, and how he progressed in the last 6 months to 1 year regarding the interstitial lung disease, including fibrosis. Number two, I will subject the patient for a pulmonary function test spirometry, which most of the patients are difficult to do a adequate spirometry. I will try to do a DLCO and sometimes, if possible, available CPET also. And what I will definitely do I will look into the saturation. I will look into the oxygen saturation level and the resting hypoxic level, and I will evaluate for an presence or absence of pulmonary hypertension. And in considering all these factors, if the surgery is mandatory, I will advise the anesthetist to go for a lung protective ventilation, a very low FI2, which would maintain a saturation between 88 to 92, something like that. A very judicial use of fluids rather than a liberal use. And even in the postoperative period, the same thing has to be continued, like an early mobilization, early weaning. That sort of advice also will give to the anesthetist and the surgeon. That will be my approach.
And probably, I 100% agree with you, sir. And if the general anesthesia is required, probably prepare mentally that the patient family, this patient may
exactly.
may lose their life, because IPF, for example, if intubated, there is a fair chances that 30-40% of times the mortality rate, mortality chances. In such patients, what we need to do is we should electively tell the team to convert into tracheostomy and then ensure a smooth weaning from ventilator. But of course, very, very difficult, challenging situation. Every patient has to be assessed individually and taken into consideration. Dr. Nandini, okay, a patient with ILD comes into emergency with acute worsening of breathlessness. That can be, so many things. So what is that, in the middle of the night, your resident would call you saying that this is the scenario. In first 2 to 3 years, which is a game changer essentially, how do you think, and then what are the tests that you will advise? What sort of diagnostic algorithm goes in your mind?
So, when a patient of acute exacerbation of ILD lands in an ICU or an emergency, we should actually spend
acute
50
deterioration, not exacerbation, acute deterioration.
acute deterioration lands up in the emergency. First 15 to 30 minutes, we would assess the patient. We would manage his airway, breathing, circulation. We would give him appropriate ventilatory support, which is required, and simultaneously look for the history and temporal association of fever, infection, any infectious contacts, any history of immobilization, any VT risk factors, or any cardiac symptoms. And then simultaneously, we would do a bedside assessment with a POCUS to do a dedicated lung ultrasound and a cardiac ultrasound to detect any pneumothorax, any pulmonary edema, any new onset RV dysfunction, etc. Within the after this 30 minutes, we would then spend time around 1 or 2 hours to send all his basic blood workup, including a procalcitonin level, all his cultures. If he's producing sputum, we would send sputum cultures, and if we could, if it is available, we would like to send a respiratory multiplex viral RT-PCR for circulating viruses at that time, and then I would empirically start a treatment for the patient. And if the patient is stable enough, then I would like to go for an imaging, which can be an HRCT or a CT pulmonary angiography, depending on the clinical status of the patient. Like if why we would want a imaging, because we want to see that whether this worsening is because of the ILD progression or there is an infection. So and I would subject this patient directly to a CT pulmonary angiography. Like if this patient was coming in OPD, was not having any resting hypoxia, but his cardiac functions were normal, and now he has presented with sudden onset dyspnea, hypoxia, new onset RV dysfunction, strain pattern on ECG, and VT risk factors, then I would directly go for a CTP in such patients. So this would be my algorithm. And since patients of ILD are on immunosuppressants, we should upfrontly be looking them for infections like opportunistic infections like pneumocystis, CMV, mycobacterium, fungal infections, etc. And as stated by ma'am, bronchoscopy doesn't fit in this routine algorithm, because as per the current definition of exacerbation of ILD by Collard et al., infections are inclusive in the definition and it's not exclusive. So BAL would only be done if necessary and the patient is stable enough. That's it.
Absolutely brilliantly put, Dr. Nandini. Again, it is very, very important. We should, when we are following our patients and then they suddenly land, it can be infection, it can be, as Dr. Nandini said rightly, it can be sometimes, a fungal infection, it can be other opportunistic infections or mycobacterium kind of thing. Appropriate imaging should be considered, and then appropriate. For that matter, I would love to, bring in few of my cases in the recent 1 year. What has happened is, it was identified as a invasive pulmonary aspergillosis, that is the culprit. So rather than starting 2 days, 3 days down the lane antifungal, if it is in a given appropriate scenario, upfront start antifungal and then later on de-escalate. That is more important, because sometimes the buffer systems what our ILD patients will have is very, very less, and then the chance of them, once they go on to mechanical ventilation, they will not make it. And then now coming to, I request all my panelists to be very brief in the round 6. This is the last round. And this round is from concept to Indian model of care. Yes, we read so much, we discuss so much. And then most importantly, what is the importance of these webinars, particularly from CCI, is CCI delivers what is practically game changers. So that way, those points will take it now in the last 10 minutes. Sanjay sir, so how can a treatable traits model be made realistic in smaller Indian cities where complete ILD and MDT is unavailable? To be honest, MDT and multidisciplinary discussions are unavailable even in majority of centers of Hyderabad. For us, we started probably 2 years back. Of course, we started one of the first ILD clinic in entire Hyderabad way back in 2016, and we did a big conference called Aspire on ILD in 2016. So the later on, the routine MDD means I pick a phone and then ask my radiologist, this is what is happening to my patient. Can you please look the imaging and then tell me? I pick the phone and then check with similarly with my rheumatologist and then with my pathologist as well. That's what used to be MDD. But now, fortunately, for the past 2 years, what we are doing is we are doing proper ILD boardroom discussions. And then, to be honest, if you haven't started it, start with your radiologist, pathologist, and also rheumatologist. This is going to enrich your experience, and also the subsequent patients will get definitely much be at a very good advantage for with this ILD boardroom discussions. I'm sorry, sir. Sanjay, sir. Over to you, sir.
So, really, it is very challenging under resource setting. But we will have to do it so it can still be implemented with a structured assessment, repeated review, and selective MD input. A workable model would be the local physicians must be aware of some treatable traits, and he must look for some treatable traits like exertional hypoxia, need of oxygen, dyspnea burden and functional limitation of the patient, cough burden, airway disease, reflux or aspiration risk, reduced exercise capability, and anxiety. All these to be taken care of. Then he must take help from the referral hub for better HRCT review. And ultimately, he can take remote multidisciplinary consultation through phone, online, as you are describing that you are doing earlier. So it is still possible, and it is plausible for the smaller cities. Doctors sitting there may have the contact with you and the others to take care, and the pathologist, the radiologist, rheumatologist on the phone or online, so that a remote MDT can be done, and so the patient can benefit.
So essentially what Dr. Sanjay sir is mentioning is forward your videos to one of the CCI pulmonologists. CCI pulmonologist will put it in the CCI Ultra group, and within next half an hour to 1 hour, MDD happens. A pathologist comes in, a rheumatologist pops in, and then multiple expert pulmonologists will come in, and then will give you a very good diagnosis, and then expert level MDD is CCI Ultra discussions.
Cardiologists are doing such things in ECG and echo.
Yes, sir. Thank you, sir. JP, sir. So, when coming to patients, sir, okay, what happens is they'll have their own side of the story. They may have cough, they may have a breathlessness, they may have sleepless nights kind of thing. But as a clinicians, we think on the opposite side. We want evidence-based recommendations. We want what are the things that is going to reversible, and then what is the strength of feasibility of implementation of our treatments, and then we want to decrease the morbidity and mortality. And then my question to you is, sir, so how do you describe, or could you describe your hierarchy for the first consultation? What is the priority, and how do you take it in you practically in your cases, sir?
So the question is, if there are multiple number of treatable traits, which one will be the priority? I will prioritize, actually, I will look into the immediate risk, immediate dangerous traits, which I can address, like a pulmonary embolism, an acute infection, or a severe hypoxia, or that sort of things I will be looking, which are going to cause an immediate mortality or immediate worsening. So that will be my first looking and addressing. Then I will look what are the factors which can modify the or prevent the disease, like when there is an antigen exposure for a hypersensitive pneumonitis, when there is an active inflammation, I will look into that factor, or a drug which is causing that. I will try to address that treatable trait. Number 3, what are the things which can modify, like an obstructive sleep apnea, malnutrition, the other symptoms like severe cough, severe breathlessness? I will give priority to that. Last, or the fourth component which I would address will be the like a long-term management, like rehabilitation, a long-term oxygen therapy, that factor. So my
care approach kind of thing.
That will be my approach.
So JP sir is very clearly mentioning identify the traits which will bring a lot of impact in the patient population, and then ensure you treat them. Second important thing is, what are the things which are quickly modifiable? If there are things like, as sir said, infection or pulmonary embolism, the moment you manage pulmonary embolism, patient's lifestyle is going to drastically change. So high impact, high modifiable things should be prioritized while treating the patients when there are multiple coexisting traits. Coming to Dr. Nandini, biomarkers like KL6, SPA, SPD, CCL18, telomere length, and multi-omic signatures are scientifically exciting. And which are ready for clinical decision making, which are currently prognostic only, which should remain with research settings. What is your take?
Basically, the more prevalent biomarkers like KL6, SPD, SPA, CCL18, and MMP7, they are basically adjuncts to therapy. They are prognostic markers. They cannot be clinically actionable. So they have a role in predicting fibrotic phenotype and prognosticating a patient, but they are not clinically actionable. And even the transcriptomic markers and the genes we have and the metabolomics marker which are in research are also not validated as of now. Only clinically actionable marker that we have currently is the telomere length, because that has clinical implications. Like if we have a short telomere length in a susceptible patient, like a young patient who has a family history of familial ILDs, has premature graying of hairs, has features like cryptogenic liver disease, young onset pulmonary fibrosis, in such patients, if we have reports suggesting a short telomere, then we will not give him immunosuppression and would just keep him on antifibrotics. So remaining markers remain still questionable, and their values are also still not validated. So currently, as of now, we have biomarkers of bad biology, but we are lacking biomarkers of treatment response. So only telomere length is what we have, which is clinically actionable as of now.
So thank you, Dr. Nandini, for that insight.
So there's a lot of research happening on KL6. I think there is data from our country also, because we have one laboratory which is
yes,
doing KL6. So hopefully we're going to get some data.
So we have at in-house, we have that
Correct.
assessment of KL6 levels. But again, the biggest challenge is what level. Yesterday, when the levels normal was around 135 to 600 something.
500.
Yesterday, it has grew in one of the patient. It has come as probably around 17,000 something. What should I say? Yes.
But also, I think there are two methods of testing it, and only one is standardized so far. So it will all depend upon what method is.
I think India, it's only one method is available.
Yeah.
There is no second method available to my best of knowledge. But Pratibha, anything,
Yes.
final comments from you? Yeah, please.
I think just a couple of things. I think as physicians, we are more concerned about patients' lung function deterioration, patients' oxygen deterioration, what are the levels. But I think for patients, they are more concerned about whether their cough is better or it doesn't worsen, whether their breathlessness, day-to-day activities, how many times they need to get admitted, how long are they going to live, those kind of questions, very real-time questions, And unfortunately, I think we don't really have answers to a lot of these questions. And I think more and more, the more deeper we get into looking at all, all these treatable traits, maybe we will impact some parts of these patients' questions, which is their dyspnea, their cough, and their prevention of exacerbations, and so their in-hospital mortality. I think those kind of things. And if I say one thing today, okay, in India, we say HP is a very high incidence. But so often we don't find an antigen exposure. Okay.
Right.
And I think in the West, in Europe, they do active finding of the environmental exposure, because unless you stop a patient from being exposed, you are not going to be able to treat them effectively. You're going to give them immunosuppression, they're going to give them antifibrotics, but they are going to continue to progress in an HP patient. So I think that is one thing that we need to do. There is one interesting study in chest in 2021 where they have said that if you have some standardized questionnaire, you'll most likely be able to figure out what is the antigen exposure for a patient when you're suspecting HP. And I think in India, we need to move beyond thinking of pigeons and think of other things as well. We very often don't only ask patients whether they have pigeon exposure or pets at home. We don't ask them for other things.
Pratibha is recommending, listen, Pratibha is recommending everyone to stop being pulmonologists and behave like detectives.
Which we anyways do. Which we anyways do, Vijay. Which we anyways do.
So, can I have JP sir final comments?
So, actually, continuation with the Pratibha madam's comment. No, whenever you have an ILD case, maybe an HP, so the day one itself, you think of a treatable component. If it is there, you try to avoid that. And don't forget about the hypoxia and the obstructive sleep apnea component, which also neglected in patients with the ILD. That's my comment.
Sanjay sir, your comments?
So the patient concern is basically the quality of life and the function.
Yeah.
So they are more concerned about that, as Dr. Pratibha was telling. So we should try to find it out if any treatable cause can make their life better, and we should treat it properly so that they can have experience a better quality of life, or they can function in a better way. So that's very important.
Thank you, sir. Dr. Nandini?
Just thank you so much for the opportunity, and everything is covered. Nothing for the final comments from my side.
Okay.
I think nutrition and pulmonary rehabilitation, these are the two things which we don't land up focusing on. Our patients are on so many pills, they cause gastritis, they're eating poorly, losing weight. I think nutrition is another important thing that we need to focus in our patients.
So I'll take only 5 more minutes. I think Tridib was cursing me. He was messaging me in personal window as well, saying that you are not asking my questions. Tridib Bhai from
Mumbai.
He's from Mumbai, from a young pulmonologist from Mumbai.
Youngest pulmonologist.
Youngest at heart. Okay, yes. Recently, he has given me a treat at Goa. That was it's a memorable thing. So all your questions were addressed to the Bhai. Okay. So in view of shortness of time, I'm not reading. But thank you for so many questions you have asked. And Dr. Aman, who is asking from Ranchi, kindly enlighten on biomarkers. We have done that, Tridib Bhai and Aman Bhai. Thank you so much. And all the...
Tridib has asked a question that if you have a short telomere, would you ask them not to have kids? So I think, Tridib, you can send, since you're in Mumbai, you can send them to a genetic specialist, Mamta Muranjan at SRCC. She is a pediatric genetic specialist. Maybe she will be able to counsel the parents.
Fantastic. And
I don't have an answer for that, so sorry.
Yes. No, it's practically something which is now with the advent of so much of infertility management like surrogacy, all those things. There's a lot that we can, because now I don't know how far it is in India. They are taking off the disease-causing genes and then injecting the doing IVF.
Is that happening in India?
It is. I don't know about India, but that is happening
in the world. Yes, yes.
Right. So, Tridib Bhai, whom you are asking, I will call you and then inquire later on. And so, coming to all the great things will end at one point of time. Of course, in next fortnight, we'll catch up in next CCI webinar with a different topic, as Dr. Pratibha was mentioning very clearly. Nutrition and its importance. So September 1st week is Nutrition Awareness National Week, and then we are planning a webinar on nutrition and chronic respiratory diseases. Make sure you tune to CCI to follow, contribute for CCI academics. And thanks, I sincerely thank CCI Central Committee, particularly Krishna Anna and Narayan Pradeepa, Ashish, Anil, and Shivani, our own Atribai, Ravi Dosi, Kirat, for their relentless back-end support in making this, webinars a huge success. And I sincerely thank my dear, wonderful, lovely panelists, Sanjay sir, Pratibha, Nandini, and JP sir, for their. I don't know. No, it's a. I can only say it's a tons of literature. It's now I feel like after completing this webinar, it's like encyclopedia on treatable traits we have given through this webinar, and sincerely thank our pharma sponsors Lupin for their unconditional support. And my conclusion for all the listeners is patient-centric approach always is important. Yes, the disease label plays a very, very crucial role, but what does patient needs? What can be identified as a trait? What can be modified? And then objectively, what can be made better in the patient lives? More importantly, don't treat our particularly ILD patients. They come with a lot of suffering. Give that extra few minutes of your valuable time. Sometimes empathy can be your treatable trait. Giving your time itself, is the most important thing for the patients. And then I was going through, there's a diet modifications for autoimmune patients. Across the globe, they follow. We hardly consider. All these things we should ensure and then deliver to our patients to increase the standard of care to the global standards in Indian ILD patients. The mnemonic, don't forget traits, TRAITS, which means 1, transcend the diagnostic label. You go beyond the diagnostic label. Recognize the modifiable disease drivers. A, act on high impact traits as a priority. Individualize the priorities. Talk to the patient and then what he wants, please check with him and then get it delivered. Treat through multidisciplinary team. That is very, very important. So MDD, even if it is not possible, okay, then pick your phone and discuss the case over phone or send it to CCI life member and they will discuss in the ultra and then get back to you. Shared discussions, that is decisions and reassess. Always put the patient front and then discuss with patient and patient family what they need and then get it delivered. And with this, I would love to conclude today's webinar. And thank you, technical team, Bijal and Vinod and Amit as well. With loads of love and respect to all my colleagues. And signing off, Dr. Vijay Kumar.
Thank